Welcome to the Glucose Never Lies podcast, where science meets real-life experience to empower diabetes management. I'm John Pemberton. I've lived with type 1 diabetes since 2008 and have spent nearly 20 years mastering both the science and art of managing it. Through personal experimentation, published research, and my work as a diabetes specialist dietitian, I've gained deep insights into what truly makes a difference. When my son Jude tested positive for type 1 diabetes antibodies, I realised that all the knowledge in my head was wasted if I couldn't communicate it in a way that was clear, actionable, and easy to come back to. So I built the Glucose Never Lies education programme, a free online resource designed to teach people diabetes management exactly the way I'd want people to understand it if they were looking after my son. After battling a functional motor disorder for many years and recently experiencing a major depressive episode, I was eventually pulled out of that hole by my friends, family, and professionals who helped me get back to being me. That experience taught me the power of giving, and this podcast is my way of giving back. My co-host Louise is a highly experienced diabetes nurse with over 20 years in the field. She brings a wealth of knowledge, and her superpower is making complex diabetes science accessible and practical for everyday life. She is the best diabetes nurse I have ever worked with, and there have been some good ones. Most importantly, she keeps me in check and keeps the podcast on point. So, if you're living with diabetes or supporting someone who is, we want to make things easier, clearer, and importantly, more enjoyable. We hope you enjoy the content. If you do, please share it with those who may like it too. As a disclaimer, the information shared on the Glucose Never Lies podcast is for informational and educational purposes only. While we discuss strategies and insights for diabetes management, this podcast is not a substitute for professional medical advice. Always consult your healthcare team before making any changes to your diabetes plan. That done with, let's get into the content. Welcome to episode 15, which is C-Peptide. What type of type 1 diabetes do you have? So this sounds like a strange title, but I'm sure if you've been around diabetes management for long enough, you'll have heard the term brittle diabetes. And I can remember the first time I heard this, I just thought, that's just basically an excuse for people saying they've got it harder than other people when everyone's got the same condition. But actually, as I've looked further into it, there's definitely something in that. And it's generally people who have quote unquote brittle diabetes who've been diagnosed at a young age for a very long time. And they seem to have real issues with their glucose management compared to other people. So really, not all type 1 diabetes is kind of born equal. And that's what this podcast is going to look into. It's going to look at it, what defines or determines whether someone has maybe an easier ride with type 1 diabetes than somebody else, and what numbers do we need to look at in certain metrics such as C-Peptide, which will give us a clue if you have type 1 diabetes, where you sit on the level of challenge that you'll have. And also from a healthcare professional's perspective, it can sometimes be extremely important to know this number because you might want to prioritise people for advanced technologies and second-line therapies for the people who are really struggling because they're having more challenge than someone else. So that's the whole aim of this podcast, is to unpack why it is that some people have an easier ride with type 1 diabetes than other people, and most importantly at the end, what can we do about it as individuals with type 1, and what can healthcare professionals think about depending on the level of challenge that people have. So just to kind of put this into perspective, we know that when you're first diagnosed, you have a honeymoon period where your insulin doses are low, where the pancreas is still producing some insulin and helping out. And we know that the longer the honeymoon lasts, the longer the beta cells produces insulin, the reduction in complications, and also certainly excursions overnight. So the longer the honeymoon lasts, the better it is. And really, what we want to try and determine when you have type 1 diabetes is where do you sit on that scale? How much residual insulin production have you got left from your own pancreas? It won't necessarily be zero, but it will be low enough to require certainly insulin to survive. But there's some people who produce more than others. And the test that we need to do for that is a C-Peptide test. So when insulin is produced in the beta cell, it's called proinsulin, and it's a molecule of insulin that's attached to something called C-Peptide. And when the beta cell then looks to put insulin out into the periphery, it actually cleaves off the C-Peptide, and the insulin goes and does its job, and then the C-Peptide works its way out and goes out into the urine. So actually, what we do know is that if we measure the C-peptide in someone with type 1 diabetes, it will tell us how much insulin is being produced from the pancreas, therefore give us a very good estimation of how much residual function is still left. So obviously, that is going to be helpful. And we also kind of want to know, first of all, how do we test for that? And then what are the normal ranges? So the classic way of testing for C-peptide was you would have a meal stimulation test where you would have a mixed meal and then you would test the C-peptide over the next 2 hours to see where the level is taken. But obviously that requires quite a bit of work and organization. Whereas now actually what they found is urinary C-peptide, it's actually urinary C-peptide to creatinine ratio can be taken and converted into what your C-peptide level is. And the evidence that suggests that that's very, very tightly correlated with the C-peptide levels from mixed meal tolerance. So the beauty of that from clinicians and a person with type 1 diabetes is all you need is a urine sample, and that can be taken obviously at clinic and it can be sent off, and you can know your C-peptide number with a very accurate level. So if you do get that tested and you're thinking, well, right, what is my level of C-peptide and what does that actually mean? Well, there's kind of some cutoffs which give you an idea of how much insulin production or residual pancreas beta cell function you have that produces insulin to help you out. And really, I'm going to tell you in nanomoles and picomoles because you might get it in either. So someone who's got a high residual function, still got a lot of insulin being produced by their pancreas, well, not a lot, relatively a lot to someone who's producing nothing, but was very helpful, is either greater than 2 nanomoles per litre or greater than 200 picomoles per litre. Now, normally you get your value in picomoles per litre, so greater than 200 would represent someone who has type 1 diabetes, but gets good help from their own pancreas. And then there's people with intermediate residual function, anywhere between 0.03 and 0.2 nanomoles per litre, or the more usual measurement between 30 to 200 picomoles per metre. They've got intermediate residual function. And then someone who's got low residual function, virtually no help whatsoever, is less than 0.03 nanomoles per litre or less than 30 picomoles per litre. So to put this in perspective, a person without type 1 diabetes would have 1 to 3 nanomoles per litre or 1,000 to 3,000 picomoles per litre. So even if someone with high residual function still requires insulin, is going to have a challenge with type 1 diabetes. But obviously, if you're in the high, intermediate or low group, your challenge with type 1 diabetes may be very different. Just to kind of put this into perspective of who's likely to have this, people who are diagnosed in their first 5 years, up to 48% of people still have high function. But by duration of diabetes, 5 to 15 years, that only drops to 8% of people in the high range. So you can see that the function drops over time, and certainly by 5 years in, most people have gone from a high level down to either intermediate or low. The downside for people who are diagnosed under the ages of 18 is pretty much every single one of those after 5 to 15 years they were not in the high group. So the younger you're diagnosed and the longer you're diagnosed for, unfortunately, that means that your C-peptide or residual insulin function is going to be much lower. So younger people have it harder and they have it for diabetes for longer. So in general, they're the ones with the lower C-peptide levels. And usually the younger that they're diagnosed as well, obviously causes some specific challenges with that. But pretty much if you're diagnosed under the age of 20, by 15 to 35 years of type 1 diabetes, pretty much there is low residual function in general. So under 20, diagnosed for 15 years plus, it's likely that you'll be in the low category, but you can always get it checked to see. So now you kind of have an idea. Just to put this in perspective, is I said before that, kind of you think, well, what people on about brittle diabetes don't think it's that difficult. Well, that's because I was diagnosed at the age of 27. I'm only on 30 units of insulin per day, which is 0.3 units per kilo or so, which is actually a low insulin requirement. Then I had my C-peptide tested and mine was 220 picomoles per litre. So I'm one of those very lucky people who have a much easier ride with type 1 diabetes because my pancreas is still producing function. And that was still 10 years after diagnosis. So again, my biases about how not easy diabetes to manage, but maybe I didn't feel it was as difficult as some people were making out. Well, that's because probably those people have got a low residual function and no help. So it's important to understand these things, because certainly the clinic that I work in, it really gives me some empathy for the people who are really struggling with those basically low levels. And just to kind of give you an idea, that when they had the classic landmark study, the diabetes complications and control trial, they took 610 patients who had their C-peptides measured, and those with the high function, with the greater than 200, had the lowest HbA1cs, the lowest fasting glucose levels, the lowest total daily insulin, and again, that's got 7 years follow-up. And then when they did the further follow-up at 35 years to see what the risk was for their complications, the people who were in the high group, high function, had the lowest HbA1cs and the lowest risk of eye disease compared to the people who had low function. And it was basically a dose-response relationship. So really kind of what you're looking at is lower complications and also less risk of severe hypoglycemia as well. So essentially, the more C-peptide you've got, the less risk of complications and the less risk of severe hypoglycemia. On the flip side, the lowest function that you've got, those risks actually increase. And to give you a bit of an idea in today's metrics, a team in Newcastle took 66 people with type 1 diabetes in the free living world, and they looked at them, and the group in the high residual function had 76% time in range overnight compared to only 58% time in range in the low group. And that's basically because overnight, when there's no food or nothing else, the residual insulin from the pancreas is able to just nudge that glucose level back down into target. Whereas if you don't have any of that residual function, you're less likely to have that happen. And similarly, after meals, the group with the high function had 68% time in range compared to only 50% for the low group. So again, after eating, you're getting a little bit of extra help. Furthermore, they did further studies on people, on the 30 of those adults with type 1, and they did exercise for 45 minutes. And in the 12 hours after exercise, the high group had 73% time in range compared to 40% or so in the intermediate and low groups. So again, having that residual insulin function around exercise is really beneficial to reducing the risk of glucose levels not being in target around exercise. So everything kind of points towards a higher C-peptide, a higher residual level of insulin function, the easier you're going to find diabetes management in terms of glucose levels. The lower that level, the more challenge you're going to find it. So the question is why? And there's two main things. The one pretty straightforward thing is we know that insulin from the pancreas goes directly into the portal vein. So therefore, when you eat food, more insulin's in the portal vein, more of the glucose gets captured in the liver before it makes it out into the peripheral circulating blood, which means that less post-meal highs, for example. And the second equally important part is when the glucose level rises in the portal vein, it actually increases, well, in theory, it should increase insulin production and also glucagon production, because increased glucose levels paradoxically increase glucagon levels from the liver. But normally in a pancreas that doesn't have type 1 diabetes, the insulin that's produced from the glucose rise will have a negative feedback loop on the glucagon and stop it being produced. But obviously, if you do have type 1 diabetes and you've got low or no residual insulin function, the glucagon levels actually spike after eating. So if you're someone who's got a higher function, you get a little bit more benefit because you get less glucagon production after eating. And again, the glucagon then goes to the liver, pushes more glucose out and makes it more difficult to control. So again, that's the reason why it helps store more glucose in the liver and lowers the glucagon level, therefore keeping the actual glucose in the liver, which will control post-meal highs and also be careful of not causing severe hypoglycemia as well. So you can see that's why it's happening. And why is it important to potentially understand this? So we started having a look at this where I work at some particular patients who are having really difficult challenges, and at the time, we only had limited funding for particular advanced technologies like hybrid closed loops. So we actually prioritized a few of those patients who had basically less than 10 picomoles per litre to go on to the hybrid closed loops first, because they're the people who are having the hardest time. And again, when it comes to thinking about adults with type 1 diabetes and the funding is more limited, if you're someone with very low residual function, that should actually boost your rationale for getting one of these systems, because if your insulin production from your pancreas is not able to support your control, you want a hybrid closed loop who can switch on and switch off the insulin according to the glucose level. The second one we've covered in the insulin resistance podcast number 14. There is emerging that GLP-1 therapies like semaglutide and tirzepatide, and the older ones, exenatide and duaglutide, are actually very effective at lowering glucagon levels because they have a negative feedback on their alpha cells of the pancreas. So if you're someone who's got a chronically low insulin residual function, then you may be someone, if the GLP-1 therapies come out for people with type 1 diabetes to support control, you should be first in line compared to someone with high function because they're not going to need it as much. Similar for things like amylin, which is another hormone that's generally produced from the pancreas that can help control glucagon levels. So that's kind of from a technology perspective. But then the other thing to think about is if you're someone with virtually no residual insulin function at all, you can think about bespoke nutritional strategies. You'll need to be a bit more careful with your exercise strategies. You might want to be careful with some of the meals that you choose. So for example, I look after a young triathlete, and she's someone who has a very low C-Peptide and has particularly difficult challenges with glucose levels in general, but around exercise because it's just very difficult with not having your own circulating insulin from the pancreas controlling things. So some of the things when we knew that, what we knew it would be a good idea to do is, in general, she needs a high carbohydrate diet because to fuel the exercise. But because there is very little, there's increased risk of severe hypoglycemia, what we don't want is too much circulating insulin around kind of exercise times. So we lowered the carbohydrate amounts in the meal necessarily before exercise, but made sure we maximized it at other times to make sure that she carb loaded after exercise rather than before, because we didn't want too much insulin knocking about, certainly during exercise for her. And then similarly, we would give smaller amounts of glucose every 10 to 15 minutes and keep an eye on the trend arrows from the sensor. And again, we had a particular algorithm for her before bed, depending on whether she'd done exercise, because we know she's at increased risk of severe hypoglycemia overnight. So knowing that was particularly beneficial, but also it meant that we prioritized her for a hybrid closed loop because she was having those particular challenges. Other things that you can consider, for example, as we mentioned, thinking about the GLP-1 therapies, especially if you've got a weight management challenge there, and not at the moment indicated for people with type 1. However, you may have a doctor who is up to date with the research. You might think about prescribing it offline potentially. So again, there are thoughts and considerations based on if you know what your C-peptide level is. And then finally, what I think is extremely important is empathy. So I work and see lots of children with people with diabetes and also know lots of people with type 1 diabetes. And before looking into all this, I used to think that everyone was like pretty similar in terms of their experience. I know that most people with type 1 diabetes have a much harder challenge than I do because I'm getting so much help from my own pancreas. People who've been diagnosed for 15 years and were diagnosed as a child, pretty much guaranteed to have no or very little C-peptide whatsoever. They are managing a very different beast to what I'm managing. So again, understanding that, number one, if you're someone who is having those challenges, don't be too hard on yourself because you've got a much harder job. And also, rather than people like me getting too superior about what you can do with your diabetes, it's just an important check and balance on actually it's very different for some people compared to the other ones. So this is a fairly short podcast, but I think it's just an important area. What you can take away from it is the more C-peptide you have, the more residual insulin function you have, then the more chance that your control will be in target and your future health will be easier to look after. In terms of levels, you will get a urinary C-peptide done that doesn't have to be fasting. That's fairly easy to just get from your doctor at the clinic. And then finally, decide what level you are. If you're above 200 picomoles per litre, then you're in the high, 30 to 200 intermediate, less than 30 low. And that'll give you an idea. And I guess the so what from that is, well, if you're in the low group, then maybe you should be prioritized for hybrid closed loops, GLP-1 therapies, etc. And then if you're in the high group, maybe you don't need as much help. So if there is limited resources, maybe the people with the low residual function should be the people who are prioritized in that respect. So maybe there's a bit of empathy to be drawn. And if you're a healthcare professional and you're thinking that particular patients are really struggling no matter what you do, sometimes it's nice to get a urinary C-Peptide and explain to them, yeah, it is really tough and this is the reason why, and we're trying our best and you're doing your best, so well done. Maybe 70% time in range is not possible for you given your level of C-Peptide. Maybe we need an individualized level for you so that you don't feel like you're failing. Actually, you're doing as well as everybody else. It's just that you've got a bigger level of challenge. So again, information is key. I would encourage you to check out episode 14, which is on insulin resistance, which goes through the idea that actually C-Peptide lowers your risk of insulin resistance because your level of circulating insulin is much lower, and also talks about the GLP-1 therapies. There's also the SGLT2 therapies. There's also pioglitazones. There's loads of things that can actually help reduce your insulin need that may be beneficial if you're someone with very low residual function and you've got very high circulating levels of insulin and insulin resistance, especially if you're finding it difficult to lose weight. That is a great podcast because it'll teach you how to think about lowering your daily insulin dose and give your body the opportunity to liberate the fat from its fat stores. So I hope you found that useful, and please share it if you do. Just as a note of important and really exciting things coming up. So I've been in contact with Pratik Chowdhury, who is the chair of the DVLA clinicians group for driving, and he's going to walk through with us driving regulations for people with type 1 diabetes from the expert. I've got my very good friend, Desi from Stanford, Desi Zareva. She is basically the best diabetes educator that I know. And I've recently done a Partying with Type 1 Diabetes guide, and she is going to actually interview me about that guide, a lived experience from myself and people who I know with Type 1 Diabetes who've enjoyed partying. So that is going to come up. We then got Professor Offer Moser, who's the lead author of the 2020 and 2025 CGM hybrid closed loop exercise guides. We're going to sit down at the EASD together, and he's going to walk me through his personal story with type 1, but also really the key nuts and bolts of how to manage exercise with type 1 diabetes and what the guidelines say, and kind of whatever is possible. And then finally, after that, we're hoping to have a special GLP-1 GIP, or semaglutide and tirzepatide, or Mounjaro, if you prefer those names, a podcast digging more detail into those specifically for people with type 1 diabetes, because that really is going to be the next frontier for. Insulin is great because it helps control blood glucose levels, but as we said in episode 14, too much of a good thing can be a challenge. These second-line therapies can improve glucose control, lower insulin doses. If you've got weight management challenges, help with that, but we also need to understand there are big risks in terms of hypoglycemia, being a main one, and also keep check of certain blood markers. So it's not something to be just running off and doing, but I think it's important to explore that, because over the next 3, 4, 5 years there's going to be a lot of strong evidence coming out. They're already in the public and loads of people are using them. We need to know what we need to know about type 1 diabetes for those. So yeah, please share this if you think this has been valuable, and we'll check and catch you in the next episode.